Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
I'm Elizabeth Kurkjian. As she said, I'm on the staff at Washington Hospital here, and I'm also part of Women's Health Specialists. We're a small single specialty group practicing obstetrics and gynecology here in town. And the topic tonight is diabetes in pregnancy. So, often with these talks, people come with different degrees of expertise and information, experience with diabetes. So I just want to go over what are the goals of the talk tonight. And I'm hoping that through this talk we'll learn something about diabetes, specifically as it relates to pregnancy. Also learn how gestational diabetes is diagnosed and treated in pregnancy, because things are a little bit different for our diabetic patients during pregnancy compared to when you're not pregnant. And then also learn why management of diabetes is important to have a healthy pregnancy. And you all are very knowledgeable about diabetes, so this is really very basic. As you know, diabetes is an imbalance of our body's ability to produce insulin and to use insulin. And pregnancy is a very special state. Many of our systems are changed because of pregnancy and because of the needs of the developing fetus. And pregnancy, lots of additional hormone secretion, and this really can cause a lot of changes in many systems, but also in the insulin system. And there's an increase in insulin resistance and changes in insulin production. And what happens with gestational diabetes is that if the insulin production can't keep up with the insulin resistance and the insulin requirements, increasing insulin requirements, then diabetes develops. Well, what is gestational diabetes? Gestational diabetes is essentially diabetes that develops during pregnancy. So diabetes that will show up in a woman who is not otherwise diabetic before the pregnancy. And it's quite a common problem. You know, it can affect about 2 to 5% of pregnancies, though various studies, there's quite a range that we see in different studies. But the most common figure you'll see in the literature is about between 2 to 5%. And it's more common in women of African American descent, Latino, Native American, and South and East Asian descent. And we're really fortunate to live in this area. We have such a diverse population in this area, which is really great. And but what it can mean is that we're seeing a lot of gestational diabetes. In my practice, I see a lot of women who have gestational diabetes. So what are the risk factors? Some women are more at risk for developing gestational diabetes, and these are some of the risk factors that we see. If you have impaired glucose tolerance prior to your pregnancy, then you're more likely to develop true gestational diabetes during pregnancy. So these are women who maybe they've had a test with their gynecologist as part of their routine annual exam or with their family doctor, and their sugar values aren't high enough to say, well, you have diabetes and you need to start treatment or therapies, but enough to say, well, you're in that borderline range and maybe you should be taking care of your diet, watching your diet, exercising, and being followed. And those women in that situation will often show up with gestational diabetes. If you've had diabetes in a prior pregnancy, 1 to 2/3 risk recurrence in the subsequent pregnancy. So I always am very careful to let people know about that. A strong family history, especially a history of diabetes in a first-degree relative, predisposes. Women who are obese have higher rates of gestational diabetes. If you've had a delivery of a baby, so if you've had a baby in the past that's been 9 pounds or greater, you're more likely to have diabetes in the subsequent pregnancy. As we get older, we have more of a risk for developing diabetes, just as with type 2 diabetes. And then if you're spilling glucose in your urine, that can be a sign that gestational diabetes may be in your future. Excuse me. So why do we care about this? I mean, there are some very special complications related to pregnancy over and above just the health of the mom and managing diabetes to try and improve mom's health. And these complications can be quite serious, and so we're very concerned with trying to do our best to really intervene. And my mantra with my patients is healthy mom, healthy baby. Healthy mom, healthy baby. That's really where we're going with all this. Fetal macrosomia. So this is defined as birth weight over 4 kilos or 8 pounds 13 ounces. And some people say, well, great, the bigger the baby, the healthier the baby. Well, that actually isn't true, and having a bigger baby can really predispose to certain complications. What are these complications? Well, a bigger baby may be more difficult to deliver. You may end up having a longer labor, need for assisted delivery with forceps or vacuum, maybe even need for cesarean section if the baby is too big to fit through the pelvis. A bigger baby may cause more lacerations during delivery or heavier bleeding. And a complication that puts a lot of gray hair on an obstetrician's head is shoulder dystocia, which is where at the time of delivery, the baby's head delivers, but the shoulder gets stuck. And this can be really quite a challenge to manage during delivery, and can sometimes lead to very serious problems for the baby, such as nerve damage or deprivation of oxygen during delivery. So it's something we take very seriously. Women who have diabetes during pregnancy tend to have higher rates of hypertensive disorders that develop during pregnancy, like preeclampsia. And this is important because preeclampsia can lead to things like premature delivery, preterm birth, which again has consequences for the newborn, as well as some serious complications for mom, like seizure, hemorrhage, or stroke. Another complication related to diabetes with pregnancy is polyhydramnios, where there's too much amniotic fluid. And this can again lead to preterm labor, early rupture of membranes, fetal malposition, where the baby has there's too much fluid, and so the baby just can't settle head down, and that can lead to other problems during delivery. Even more complications coming, neonatal metabolic complications. So complications for diabetes in pregnancy are not just related to complications that may occur for mom during delivery. Babies born to diabetic moms can also have difficulties. And what happens for these babies is that during pregnancy, mom is having trouble with her insulin resistance and her insulin production. And so especially for moms whose sugars fluctuate quite a bit during pregnancy, the baby is seeing a whole wide range of sugars. And the baby, though, does not have those difficulties. The baby is well able to produce insulin to take care of those sugars. So the developing fetus has really ramped up his or her insulin production. So what happens is when the baby is born, the baby says, wait a minute, where's all my sugar gone to? Now the baby doesn't have the benefit of mom's sugar, only has what he or she gets from the colostrum, formula, whatever outside sources. But the insulin production is really ramped up. So what happens with these little ones is that they can get too low blood sugar. So they can get hypoglycemia, and they can also have some calcium and magnesium derangements. And this is a problem that can be dealt with, but sometimes requires IV fluids and sometimes requires a stay in the intensive care nursery. And we really don't want to have that happen to our newborns. We really want our newborns to room in with mom, stay with mom, go home right away with mom. And then babies born to diabetic moms also can have more rates of jaundice, again, sometimes requiring a stay in the nursery and that kind of thing. So that's why we really want to try and intervene and really help to step in and try and avoid some of these complications. Okay, so I'm going to go off topic a little bit and talk about diabetes before pregnancy. And this is something that I feel very strongly about, and I think that this is an area where, as an obstetrician and as a mom-to-be, working together, we can really influence the outcome of pregnancies. And generally what we see in terms of complications and problems during pregnancy is that the better the control of diabetes during pregnancy, and that's either for moms who come in already knowing they're diabetic or moms who have gestational diabetes, the better the control, the less complications, the less risk, the less problems during pregnancy. And moms who have diabetes prior to pregnancy, in addition to the risks we just talked about, they have even some additional risks. And these risks are really tied to the level of control of the blood sugars prior to pregnancy. And moms with diabetes prior to pregnancy, especially if they are running high hemoglobin A1Cs or really erratic sugars, have higher risk of early miscarriage, higher risk of stillbirth, higher risk of perinatal mortality, which is death within the first 7 days of life, and increased congenital malformations, primarily heart and spine malformations. And these, as you can see, are really devastating complications, really devastating for families to go through some of these complications. And so the more we can do to intervene here, the better off we are. And so when I see a patient for routine gynecology, she comes in for her annual pap test and annual exam, and I ask many of my patients, are you planning for pregnancy? What's your timing for pregnancy? And for my diabetics, I tell them, I want you to come see me when you're thinking about becoming pregnant. I don't want you to wait till you're actually trying to become pregnant. You need to come in and see me when it's just a little glimmer in your eye and you're starting maybe to talk about it with your family, with your husband, and really to address some of these issues. And what I go over with these women is, first I talk about the risks associated with diabetes so that they have some understanding that this is not to be taken lightly. This is really, there are serious complications, but also you can really do something about that and you can really improve your outcome. We try and optimize blood sugars, and I'll talk about that on the next slide. Optimize blood sugars, try and get your A1C down into the normal range, and also do some testing for related disorders. We tend to see some hypothyroidism and that kind of thing related. And then for women who have had long-standing diabetes, who maybe are juvenile onset diabetes or have had type 2 diabetes for a while, sometimes there can be other vascular eye complications, that kind of thing. And we really want to get all of those maximized prior to pregnancy. Any therapies that you may need, any treatments that are being recommended, really to optimize those problems, any blood pressure issues, because the more stable those problems are when you come into pregnancy, the less problem you're going to have during pregnancy. And then also, often when someone becomes pregnant, some treatment, there are certain treatments that might not be recommended and you have to delay treatment for certain things. So we really want to get all of that optimized before pregnancy. Now, one of the things I come up against quite a bit, especially with my moms-to-be that are diabetic prior to pregnancy, is they may come in to me and they may say, I'm ready to get pregnant, Dr. Kurkjian. My family doctor says my sugars are good. After meals, I'm less than 160. My fastings are in the low hundreds. I'm exercising. I'm doing a good job. My doctor's really happy with what I'm doing. And I'm in the difficult position of saying, this is great, but this is not sufficient for planning for pregnancy. And we have very strict guidelines for our pregnant patients and our moms-to-be. We try and get their fastings between 80 to 100 and 2 hours after meals less than 135. And we really step up the monitoring and really want to try and get the hemoglobin A1C in the normal range. And again, not to try and be mean and crack the whip, but just to try and make sure that we don't have serious complications during pregnancy. And sometimes this can take time. I mean, if you have diabetes yourself or if you've known folks with diabetes, it can sometimes take a while to adjust your food plan, to get your sugars in control. And we're really asking for our diabetics to really go an extra step and do it pretty quickly. So it can be quite a challenge. Okay, so that's my little soapbox for diabetes, for women who have diabetes prior to pregnancy. So let's go back to our topic at hand, which is gestational diabetes. So how do we find our diabetics? Unfortunately for me, they don't have a sign saying, you know, I'm diabetic, help me. We have to actually go test and ferret them out. So who do we test? Well, at this point, we test everyone. There's a lot of discussion about universal screening versus universal, by universal I mean all pregnant women, versus just screening versus family history. But in this community, we really have followed the idea that every pregnant woman needs to be tested for gestational diabetes, because many women, you know, as we saw, there are risk factors and things that are red flags to us, but many women will show up with diabetes, gestational diabetes, even who have no risk factors at all. And we want to take care of those women too, not just the women who have risk factors. So when do we screen? Well, we usually do screening between about 24 to 28 weeks of pregnancy. That's the recommended time. There are some women that I will screen early, and by early I mean at the beginning of pregnancy when they first present, or we try and get some people tested right at the beginning of pregnancy, though sometimes the nausea and vomiting of pregnancy will prohibit that, and sometimes we have to wait a little bit longer. But for my folks who have, who I'm a little bit more concerned about, I like to try and get them tested by about the 4th month of pregnancy. Women who have a history of glucose intolerance, so if you're that person who has said, you know, my doctor has kind of been watching me, my fasting sugars are borderline, those folks I like to test early. If you've had diabetes in a prior pregnancy, as we heard, 1/3 to 2/3 recurrence rate, so those folks get tested early. If you've had a large baby, if you're already spilling sugar in the urine, or if you have a strong family history of diabetes, depending on your family history, I may also test those women early. So how do we test? Well, we use a 50-gram oral glucose challenge test, and this test has some good features and some not so good features, but generally what it is we give our pregnant women a specially formulated drink that contains 50 grams of glucose, and it tastes kind of like a super sweet soda, and I recommend to keep it in the refrigerator before you drink it, just not because it needs to be refrigerated, just because it tastes a little bit better, because it's kind of sweet. So you drink this drink, you go to the lab, and you have your blood sugar checked an hour later, and a value that's 130 or greater is considered abnormal for this test. And the nice thing about this test is you don't have to be fasting, you don't have to really control any food intake prior, you can do it in the morning, afternoon, so not too restricted. The only consideration is you have to make sure that you're within that 1 hour, you're at that 1 hour window for the test. This is a screening test. It's not a diagnostic test, and it's designed with these levels that we use of 130. It's designed to pick up about 90% of women with gestational diabetes. And the way I think about this test is it's kind of a big net that we throw. So we've got a whole group of people, and some here, some there, gestational diabetes, and some aren't. And in order to catch the gestational diabetics, we have to put this big net out, and we're going to draw into our net some women who are normal. So at about 20 to 25% of pregnant women will test positive with this test. That doesn't mean that many have gestational diabetes, but for whatever reason, they'll come up with a positive test. So what happens when you have a positive screening test? Well, you go on to do a diagnostic test, and the test that we use is an oral 3-hour glucose tolerance test. And if any of you have ever taken this test or know someone that's taken it, it's about as much fun as taking a cranky 2-year-old to the grocery store. I mean, it's really not that much fun to do. You have an unrestricted diet a couple of days before your test, so we don't try and restrict carbohydrates, anything like that. Actually, we ask that you eat adequate carbohydrate. You come in fasting first thing in the morning. You have a fasting test done. You get another lovely drink, which now has 100 grams of glucose, so twice as sweet. And then you sit around the lab. You have blood taken at 1 hour, 2 hours, and 3 hours. So it's quite intensive. And if you have 2 or more of the readings that are abnormal, you get a diagnosis of gestational diabetes. And these are the levels that we use. I've highlighted in the pink the ones that we use in our group and with the Sweet Success program: fasting of 95 or above, 1 hour 180, 2 hours 155, and 3 hours of 140 or above. So what if you have 1 abnormal value? Well, some women will do the 3-hour test, and the 2-hour is fine. I mean, they'll 3 of their 4 values will be fine, but 1 will be abnormal. And there's not really a consensus about what to do for these folks. And people say they should just be treated as gestational diabetics. Some people say no, they don't need to have any intervention. Some people will repeat the test. Generally, what I do is if I have someone who has 1 of the 4 abnormal, I ask them to watch their carbohydrates, especially to watch their simple carbohydrates. And I give them information about the diabetic food program that we use, just to have some guidelines to follow. And if I'm very suspicious, if they have other risk factors, then I usually will request that they repeat the 3-hour glucose tolerance test in about 4 to 6 weeks, depending on when they do their first test. Okay, so how do we manage diabetes in pregnancy? Well, diabetes in pregnancy, I think, has some management things which are similar for folks who are not pregnant, and also has some things that are very specific for pregnancy. And the treatment is really kind of multiple approaches. We try and do work on meal planning, blood sugar monitoring, exercise, and medical therapy. And probably all of these components are familiar to you if you are living with diabetes or have family members that are living with diabetes. But we do try and tailor them specifically to the needs of our pregnant patients and the special situation that is involved with pregnancy. We are really fortunate in our community to have access to a Sweet Success program. Sweet Success is a California gestational diabetes management program, or diabetes and pregnancy management program. And it is a great program. And as an obstetrician, I'm really fortunate to be able to work with the Sweet Success group. It really saves me a lot. It allows our patients to have a one-on-one, really in-depth educational information about diabetes, really focused meal planning, a lot of good, not only information, but good monitoring. And so we're really fortunate to have a great program here. It's a multidisciplinary team approach. So when folks get plugged into the Sweet Success program, they'll meet with a nutritionist, they'll meet with a diabetic educator. Those folks work very closely with the obstetrician and also with our endocrinology colleagues in the community if that's needed. We try and focus on culturally appropriate treatment. It's really difficult to get folks to change their eating patterns and what they eat. I mean, food is so important to us culturally. We share meals with our family. We may have kids at home that will only eat, foods that start with the letter M, or, you never know. So it's really tough to sometimes get around some of these issues. And I think it's really important to be culturally appropriate and to look at what people are eating and to say, yeah, great, that's a great thing, please keep eating that. No, maybe that's good for other reasons, but maybe not so good for management of your diabetes. And as always, we try and use as much as possible and as available evidence-based practices. So when do we start treatment? Well, no time like the present. And the thing about pregnancy, for better or worse, it always ends, and it has a finite time, and so we don't have a lot of time to get folks on board with gestational diabetes management. Often when someone's diagnosed with diabetes and you're not pregnant, you may go see your doctor, depending on how severe your problem is. You may be told, watch your diet, exercise, come back, see me in 3 months, we'll do another blood sugar. Yeah, looks pretty good, maybe a little bit more work here and there, come back again in 3 months. yeah, you need a little medication, let's start you on something, come back in 3 months, monitor again. Well, if we took that approach with our pregnant patients, their kid would be walking by the time they got their diabetes under control. And that's just really not appropriate for this situation. So we really try and get people ramped up pretty quickly for treatment. As I said, I am really fortunate to be able to send my patients to Sweet Success, and the nutritionist there will really help them with meal planning, with figuring out how much to eat, what to eat, and so I don't get as involved in the real micromanagement of that as the Sweet Success folks do, which is great. It saves me time to deal with other issues that come up during pregnancy. But as general guidelines, total calories are individualized according to maternal needs and weight gain. Carbohydrate intake is controlled, and patients are encouraged to eat 3 meals and 3 snacks. And that's really one of the hallmarks of gestational diabetes management, is to try and get people to eat frequent small meals with good source of protein at every meal, rather than large meals. If our insulin system is taxed, if our production and our insulin resistance is taxed, our bodies are going to do better if we're giving our bodies a little bit of sugars to try and digest a little bit at a time. It's not going to stress our insulin system out too much. If we're taking that same amount of nutrition, but we're giving it in 2 or 3 huge boluses, the system's going to say, you know what, I really can't deal with that. That's just too much at one time. But you may be able to deal with that amount over longer periods of time. So we really try and focus on eating meals and snacks. And one of the things that my patients tell me about the gestational meal planning and food program, gestational diabetic food program, is that they are asked to eat a lot of food. Sometimes they'll say, I just can't eat all the food that my nutritionist wants me to eat. And unfortunately, they don't get to sometimes eat the types of foods that they would like to eat, and that's always tough to deal with. But I'm always concerned about moms that say, that are on the diabetic diet, the diabetic food program, that say, I'm hungry all the time, because there's something going on with that. And often it's that they just don't want to eat the things that they're recommended to eat, because it is quite a bit of food. We are very strict about glucose monitoring. We ask our patients to measure their glucose 4 times a day, fasting and after each meal. We ask them to write down everything that they eat. We ask them to write down their blood sugars, so that we can look and see how their food choices are influencing their sugars, and try and make some changes and intervene in that regard. And we're pretty strict about our guidelines. I mean, we like the fasting sugar to be below 90, 1 hour after meals, 130 or below. And these numbers will vary depending on the specific program, depending on input from the physician, depending on whether or not medications are used. Sometimes if insulin is started, the guidelines might be even a little bit stricter, but that's kind of rough guidelines. And again, these numbers are often much more strict than than other family members. And so sometimes we'll have someone come in and they'll say, my mom has diabetes. Her doctor's fine with her running sugars of 160. Why can't I run sugars of 160? Or her doctor's fine with her running a fasting sugar of 100. Which, again, there's a lot of debate among endocrinologists about what a good sugar should be. So there's a lot of discussion about that too. But generally, as a rule, we are stricter with our diabetics than on the outside. We also now, as if that's not enough, watch your meals, eat 6 times a day, check your sugars 4 times a day. If that's not enough, then we say, okay, now you got to exercise. And exercise, really a moderate amount of exercise will really make a big difference. This does not have to be, 1 hour boot camp, kind of thing. 15 to 20 minutes, moderate exercise, walking can make a big difference. And my patients always say to me, I really see a difference when I do my exercise. And I'll look at, people will bring in their logs to me, and I'll look and I'll say, oh wow, look here, you had a high sugar for your after lunch. What happened? Oh, my kid was having some event and I couldn't do my walk or whatever. So we really see it influencing that. And exercising, as you know, exercise increases tissue sensitivity to insulin and improves glucose control. And then medications are also part of therapy. We generally try and get gestational diabetes controlled with diet and exercise, but if that isn't working, sometimes we'll start medications like insulin or oral agents like glyburide or metformin. And one of the things that's so frustrating for folks who are pregnant is they'll be going along just fine, doing great with diet, great with exercise, sugars will be perfect, and then all of a sudden they'll start seeing their numbers just go haywire. And they'll say, Dr. Kurkjian, I'm eating the same thing, I'm following the diet, I'm following the food plan, I'm doing my exercise, why are my sugars going up? And unfortunately, the baby is growing, or fortunately, the baby is growing, baby's getting bigger, the hormones are changing. Pregnancy is such a dynamic state that over time, it can just be more of a challenge. So many women will do great in the beginning and then sometimes end up needing medication therapy as an adjuvant for that, for high sugars. And in our community, I would say insulin is probably the preferred treatment modality right now. There are some groups that are using oral agents, and there's a lot of debate about this in the literature. Generally, I think what we find is that insulin allows us to target a little bit more carefully individual sugar problems, so allows a little bit more tailored therapy in terms of folks who are having more problems with their fasting sugars or after certain meals or that kind of thing. So most of the endocrinologists in town will favor insulin therapy for women who need some kind of other treatment. We continue treatment until delivery, so there is no break. There is no break. And then just real briefly about obstetrical management. I'm only going to talk about this briefly because it's really tailored to each individual patient. And sometimes we'll recommend doing more surveillance for our diabetic moms with non-stress testing or biophysical profile, which is a way of kind of indirectly testing the health and oxygenation of the baby. Sometimes we'll do additional ultrasounds to check for growth if we're concerned that there's poor growth or the baby's growing too big. And timing of delivery is always an issue for our diabetic patients, and whether or not to intervene to deliver them early. And we try and tailor. There's not one right answer to this. There's not one thing that we do, for everybody in this regard. We really try and look at an individual patient and if there are any other risk factors, how severe her diabetes is, any additional comorbidities that she's got going on that may influence all of these issues. So this could be a whole lecture series in and of itself. So what happens after delivery? Well, the good news is that 90% of women who have gestational diabetes will have normal sugars after delivery. And we will do some sugar testing after delivery, and sometimes some women will need some insulin immediately after delivery, because labor and delivery is a very physically stressful process. And as you know, stress seems to influence our blood sugars quite severely, and big physical stressors can influence our blood sugars. So often there'll be some period of adjustment. So we do check sugars, but we're a little bit more lenient with sugar levels right after delivery, and we are, for the most part, especially for women who just have gestational diabetes, we're pretty liberal with their diet after that. About 80% of women who have gestational diabetes, their diabetes will resolve after delivery completely. So that's really nice for them. Not so good news. About half of women who have gestational diabetes will go on to develop type 2 diabetes later on in life. So it's really quite a significant problem. And as we talked about a third to two-thirds will have gestational diabetes again with the next pregnancy. So we do have to keep those things in mind. Follow-up postpartum, we usually do some blood sugar testing about 6 to 8 weeks postpartum. Generally, I give my diabetic patients a 6-week holiday where I say, you know, you don't need to check. If things are looking good, and this is primarily for the gestational diabetics, some of the folks who are pre-gestational diabetics, we may have other recommendations, but you know, I say you don't need to check your sugars, you don't need to worry about your diet, you know, eat what you want. If you want to check your sugars now and then you can, or if there's something unusual going on. But generally I say you don't have to test your sugars. Then when they come back 6 to 8 weeks, then we do a glucose challenge test for them. And recommendation, because there's such a high rate of type 2 diabetes for gestational diabetics later on in life, we do recommend ongoing surveillance and screening for diabetes as part of your regular annual checkups. And I've seen various numbers. You know, some people say you should test every year, but at least every few years for sure you should be screened for diabetes. And then of course with, you know, in order to try and not develop diabetes later on in life, you know, or try and delay development, you know, trying to make sure you maintain good body weight, you know, as close to the ideal body range as possible, regular exercise, you know, all those things our mom told us to do. And generally for our for our postpartum patients, we use a 75-gram glucose tolerance test, and these are just some of the levels that we look for after delivery for our follow-up. Okay, and then if you want more information on this topic, these are some websites that you can go to. The first one is our group's website. The .gov is the California Sweet Success program, and they have some great handouts about gestational diabetes. Of course, Washington Hospital has a good website related to diabetes, the American Diabetic Association, and then Up to Date is a subscription service that many doctors use for medical information, but they have a patient arm, or patient section also where you can download and look at handouts on different topics. The last one, the Up to Date, isn't on the handout, so if you're interested in it, you can just jot it down.